Kidney transplantation refers to the surgical transfer of a healthy kidney from a donor into a patient whose kidneys have failed, termed end-stage renal disease, ESRD. Kidney transplantation is considered the optimal renal replacement therapy for ESRD compared to long-term dialysis. It tends to substantially improve patient quality of life, livelihood participation, cardiovascular health, and long-term survival rates. Causes of kidney failure include chronic glomerular tubular disorders, destroying functional nephrons over years like chronic glomerulonephritis, hypertension, or diabetic nephropathy, acute loss of kidney function from shock states, sepsis, toxins, drugs causing acute tubular necrosis, congenital absence or loss of both kidneys requiring early transplant, polycystic kidney disease with massive cyst enlargement compressing renal tissue, urinary tract conditions obstructing urine outflow and backing up into kidneys, certain cancers like renal cell carcinoma requiring total nephrectomy. Hemodialysis uses an external filtration machine to clear wastes fluids from patient blood, while peritoneal dialysis uses the natural lining of the patient's abdomen to filter blood inside the body. However, dialysis is burdensome, typically requiring 3 to 4 hour sessions 3 times weekly at a medical facility for hemodialysis, or several daily fluid exchanges for peritoneal dialysis. This disrupts work, activities, diet, and family life. Transplantation instead restores continuous natural filtration abilities via the donated organ. This avoids dietary restrictions and grueling dialysis commitment, allowing resumption of a fairly normal routine. As survival rates now parallel dialysis, most nephrologists recommend transplantation as optimal therapy for eligible patients. Pre-transplant evaluation. A multidisciplinary medical team thoroughly evaluates transplant candidates given the significant risks that surgery and lifelong immunosuppression pose. Psychosocial evaluations also assess a patient's understanding of the lifelong care commitment required post-transplant to optimize organ survival. Education on managing anti-rejection medications, infection prevention, follow-up care, diet, lifestyle factors, and financial impacts is provided. With evaluation approval, patients are added to the National Deceased Donor Kidney Waiting List, which follows strict algorithms allocating organs by several criteria attempting to balance urgency and outcomes. Patients may also identify and evaluate living donors able to voluntarily donate a kidney while still healthy enough post-donation. Kidney procurement. Most transplanted kidneys, about 60%, derive from patients with irreversible brain injury who meet criteria for brain death but have functioning organs amenable to donation. Remaining kidney transplants come from living donors, primarily relatives, spouses, or friends willing to freely donate one kidney for altruistic reasons. In deceased donors, transplant surgeons rapidly cool kidneys in situ while separating blood vessels' ureters before removal to minimize warm ischemia time without blood flow to preserve viability. Kidneys are further cooled in slushed ice for transport to the recipient hospital. Tissue human leukocyte antigen typing and cross-matching screens for donor kidney compatibility. In living donors, one kidney is carefully extracted laparoscopically through small abdominal incisions, sparing structures like adrenal glands and lumbar vessels. Rapid cooling is not needed, and the remaining contralateral kidney undergoes compensatory hypertrophy, sustaining normal function. Donors undergo extensive informed consent given surgery risks, including blood loss, infection, hernia, or pain issues decreasing quality of life. Living donation remains entirely voluntary, without coercion or compensation. Kidney implantation surgery. The recipient transplant surgery typically takes 2 to 3 hours. The donor kidney is surgically connected to the recipient's blood vessels, donor renal artery end-to-end to internal iliac artery, and donor renal vein to external iliac vein. Ureter connections to recipient bladder may be direct through small tunnels or use a ureteroneocystostomy, incorporating a small bladder flap to prevent backflow. Immunosuppression is initiated immediately post-transplant to prevent rejection recognition and attack against donor tissue antigens. Powerful induction agents rapidly produce immunosuppression, while maintenance regimens continue suppression long-term at lower toxicity. Common regimens combine calcineurin inhibitors like tacrolimus, inhibiting T lymphocyte activation, to block cell-mediated immune responses, with mycophenolate mofetil, which suppresses antibody-producing B lymphocyte proliferation to block humoral antibody rejection. Steroids provide broad immune tempering but minimize exposure due to side effects. Post-transplant monitoring and care. Kidney recipients require rigorous long-term monitoring and treatment to sustain transplant function and survival while balancing infection risk and side effects. Follow-up includes frequent lab tests assessing renal function through blood urea nitrogen and creatinine while tracking drug levels, annual kidney biopsies, surveying for indications of rejection like interstitial inflammation or antibody deposition, blood pressure control, early infection intervention, skin cancer surveillance, medication adjustment, and counseling on maintaining factors supporting outcomes. Types of kidney donors. Kidneys for transplant may derive from either deceased or living donors, each conferring distinct advantages. Deceased donors. Most transplanted organs in the United States derive from deceased individuals either declared brain dead while on ventilator support or suffering fatal cardiovascular injury. Living donors. Living kidney donation outpaces deceased graft survival since organs are extracted in peak condition from healthy individuals undergoing extensive evaluation. Emerging future options. Xenotransplantation. Given perpetual kidney shortages and thousands dying on waitlists every year, newer options like genetically engineered porcine xenografts show early promise. Bioartificial assist devices. Completely implantable bioartificial devices aim to assume natural kidney filtration mechanics using synthetic matrices supporting billions of renal tubule cells metabolizing wastes and producing